All right. Good afternoon, everyone, and welcome to the first webinar of the National Academy of Medicine's Action Collaborative on Countering the U.S. Opioid Epidemic. My name is Elizabeth Finkelman, and I'm the Project Director of the Action Collaborative here at the NAM. Today's webinar will last 1 hour and will follow the agenda you see on your screen. We will begin with a 15-minute overview of the Action Collaborative to be given by Dr. Victor Zhao and Admiral Brett Giroir. This will be followed by a 5-minute presentation from each of the 4 working groups. We will then share some brief announcements from the Action Collaborative and then open it up for about 15 minutes of Q&A and public comment. Questions and comments from the webinar audience can be submitted at any point during the webinar, and we will do our best to get to as many of them as we can at the end of the presentation. You can submit questions via the Q&A box located along the bottom of your screen. Simply type your question in the box at any time and click send. This webinar is being recorded, so please understand that any questions you submit may be read aloud and included in our recording. We hope you will join the conversation today on social media and tweet over the course of the webinar by using #OpioidCollaborative. And with that, I will turn it over to National Academy of Medicine President, Dr. Victor Zhao, to get us started.
Well, good afternoon, everyone, and thank you for attending the first webinar of the NAM's Action Collaborative on Countering the U.S. Opioid Epidemic. I'm Victor Zhao, the president of the NAM, or National Academy of Medicine. I'm also the chair of the Action Collaborative, and I'm joined by my co-chair, Admiral Brett Giroir, the Assistant Secretary of Health of the U.S. Department of Health and Human Services, who will provide an overview of the work of the Action Collaborative in a few minutes. I'm also joined by the leads of the 4 working groups who will present their work to date. So I'd like to start with some reflections on the genesis of the Action Collaborative and how our work together came to be. So as you all know, the opioid epidemic is one of the largest and most complex public health crises that our country has faced. Current statistics note more than 130 Americans die every day from an opioid overdose, and thousands more struggle with the burden of addiction. You can easily see the slide. This burden is human and tragic, and also it's a big financial burden for our country as well. So many organizations and federal agencies have responded to this public health emergency to date, and there's a wealth of good work happening across the nation. Organizations are authoring guidelines, establish frameworks, analyzing prescription protocols, developing education material, and figuring out how to best treat the addicted and prevent new patients from becoming addicted. However, all these excellent solutions are too often being developed in silos. They're not always shared with the other stakeholders or aligned with the other efforts. Now, we recognize the opioid crisis is complex, and there's so many factors to consider, so many stakeholders working in this space, and so many people that have been impacted. The National Academy of Medicine saw an opportunity for us and this as a significant convening power that we bring to step in and help harmonize these many ongoing concurrent efforts to ensure that the most promising ideas and initiatives are brought to the forefront. Now, shown on this slide, which is a very busy slide, you can see, it really basically makes a very important point that this is a public-private partnership. You can see the names here, particularly like CMS, CDC, ACP, ADA, Harvard, HCA, and of course the Aspen Institute, and the list goes on. Some 55 organizations span the breadth of those involved with combating opioid crisis, including, as you can see, health systems, federal agencies, state and local government, communities, patient organizations, provider groups, payers, industry, academia, and nonprofits. This is because we want to create a true public-private partnership and consider all the perspectives on the opioid crisis in accelerating solutions. It is our hope that this group will be able to help organize a multitude of approaches and solutions that have been developed to date, and then consolidate and prioritize those which have the best chance of reversing the deadly trends of this epidemic. So, I want to say a word about the steering committee and how we organize. The Action Collaborative is overseen by a steering committee that provides guidance and strategic directions. It's indicative of the uniqueness of this public-private partnership. The steering committee is co-chaired by leaders from public, private, and nonprofit sectors. For example, my good friend Admiral Brad Giroir, I mentioned earlier, is a co-chair. Dr. Jonathan Perlin, the president of the Clinical Services and Chief Medical Officer at HCA Healthcare, and Ruth Katz, Director of Health, Medicine, and Society Programs at Aspen Institute. The co-leads of each of these working groups also sit on the steering committee. The Action Collaborative has 14 sponsors that include public, private, and nonprofit entities. Most are engaged in the work of the Action Collaborative, either on the steering committee or one of the working groups. And my sincerest thanks and appreciate to our sponsors for supporting this very important work. Now, before I go into related work academies, let me say a word about Action Collaborative. The idea is the collaborative. In other words, the stakeholders come together and collectively look at the issues, collectively think about solutions, and collectively implement them. So we as the National Academy is mainly a convener, but more importantly, we're enabling the stakeholders to come together, which is the idea of working across the different silos and to identify issues which are today not yet successful and to work together collectively. So in addition to collaborative, we do have work in the academies which are totally related to the issue of opioid, which is shown in this slide. I can show you 5 studies that we are undertaking, evidence-based clinical practice guidelines to prescribing opioids for acute pain, committee on medication-assisted treatment for opioid use disorder, the review of programs in the Comprehensive Addiction and Recovery Act, the development of a protocol to evaluate the concomitant prescribing of opioid and benzodiazepine medications and veterans' death and suicide, and of course the examination of the integration of opioid and infectious disease prevention efforts select programs. As you can see, for more information, you can certainly visit our site, which is described at the bottom of this slide. Now, before I turn over to the mic to Admiral Giroir to give a more detailed overview of the work of the Action Collaborative, I also want to thank the leads of the 4 working groups for joining us today. Steve Singer from ACCME, he'll be presenting the Health Profession Education Training Working Group. Helen Bernstein from the Council of Medical Specialty Societies will present an overview of the opioid prescribing guidelines and evidence standards working group. Alonzo Plow from the Robert Wood Johnson Foundation will discuss the work of prevention, treatment, and recovery services working group. And Kelly Clark from the American Society of Addiction Medicine, she'll review the work of research, data, and metrics needs of the working group. So you can see we have an outstanding group of individuals, including, of course, not only the people in the steering committee, but the working group you're here. They've been working really hard because we all care about the same thing, which is stemming this crisis of opioid. So I want to thank everyone for their work. And now it's my pleasure to turn over to Admiral Giroir.
Thank you, Victor. And thank you to everyone who has turned into this webinar and for your attention to this critical issue facing our nation. As Victor said, my name is Brett Giroir. I'm the Assistant Secretary for Health for the U.S. Department of Health and Human Services, and I am also the Secretary's Senior Advisor on Opioids Policy, meaning that I lead the department's efforts across agencies for opioids and should be the single point of contact for anyone coming in. What you see on your slide now is just very simply to remind you that HHS has a very targeted strategy for opioids and substance uses overall that relies on 5 pillars. First is better addiction prevention, treatment, and recovery services. Second is better data tremendous work done by the CDC to really inform what the epidemic is, who it affects, and how it is evolving. Third, better pain management. 63% of people who misuse opioids do so because of pain. So we cannot solve the opioid epidemic without solving our pain crisis. Fourth, better targeting of overdose reversing drugs such as naloxone. This is a major priority for both the Surgeon General and myself. And finally, better research, which hopefully many of you are engaged in through the significant enhancement of research dollars through the NIH and other agencies. So we can go to the next slide. Victor's emphasis on how this action collaborative is cross-sectoral, multidisciplinary, and is focused on considering all viewpoints is really critical. And I wanted to emphasize that again. This is not a problem that can be solved by a single sector. This isn't a government problem. It isn't a healthcare problem. It isn't a community problem. It is truly a whole of society problem. And the only way that we are going to be able to begin making inroads to reverse the trends of this crisis is if we work together, if we collaborate to ensure that the solutions we are advancing are comprehensive, address all who are impacted, and do not exacerbate existing health disparities. As Dr. Zhao mentioned, the National Academy of Medicine Action Collaborative is composed of over 55 organizations that have committed to working together to reverse the trends of the opioid epidemic. This action collaborative was intentionally constructed to cut across all stakeholders in the opioid crisis, that we can assure that promising solutions will not inadvertently leave anyone behind. The action collaborative will exist for 2 years, and over those 2 years will work to improve coordination amongst the many ongoing programs and potential solutions to combat the opioid crisis, as well as accelerate the pace of change by identifying and advancing the most promising approaches. And I just want to say that I am personally extremely committed to this as a unique opportunity under the convening power of the National Academy to really make a difference. And that's why I so gratefully accepted the invitation of the Academy to be co-chair. The Action Collaborative is composed of 5 organizational groups. The steering committee is led by Victor, Ruth Katz of the Aspen Institute, Jonathan Perlin of HCA Healthcare, and myself, and provides high-level oversight and guidance to the working groups to ensure that our work is coordinated and that the objectives we have identified are achievable. The Action Collaborative members then divided into 4 working groups. Each working group is focused on a critical aspect of the opioid crisis, and these groups will analyze materials that currently exist, perform environmental scans of their fields to see what organizations, approaches, and solutions currently exist or are being developed, and identify and execute activities that can begin to produce actionable materials and solutions. Let me emphasize that, actionable materials and solutions. The 4 working groups are focused on 1, health professional education and training, 2, opioid prescribing guidelines and evidence standards, 3, prevention, treatment, and recovery services, and 4, research, data, and metrics needs. You will hear from each of the leads of these working groups in a few minutes. The Action Collaborative has recently developed some guiding principles for our work that I'd like to share with all of you. The National Academy will post these goals and guiding principles to their website at nam.edu/opioid collaborative if you would like to review them after the webinar concludes. Over the next 2 years, the Action Collaborative aims to first, identify and raise the visibility of complex challenges, outstanding research gaps, and needs of the opioid crisis that require a collective multi-sectoral approach. Although many of those who are invested in combating the opioid epidemic understand that it is a complex problem, we feel that it is the responsibility of the Action Collaborative itself to emphasize that a single organization or sector cannot solve this crisis alone. We also feel that it is a key responsibility of the Action Collaborative to identify gaps in the evidence base and also where dedicated focus and resources could make a difference in changing the trajectory of the crisis. This guidance will help ensure that resources are utilized most effectively and help reduce the possibility of duplicative work. Second, elevate and accelerate evidence-based, multi-sectoral, and interprofessional solutions to improve outcomes for those affected by the opioid crisis. The Action Collaborative would have no impact without identifying, accelerating, and advancing promising solutions. Our working groups will scan their fields for existing approaches and develop their own as their work progresses. The 3 items above, however, will be critical aspects of every solution we put forward, ensuring that the solution is evidence-based, that it is multi-sectoral, and considers all stakeholders, and that it is interprofessional. Third, catalyze action on shared priorities and solutions to help overcome the crisis and improve outcomes for all. The specific power of the National Academies is to bring together groups that would otherwise not collaborate, and we have done that in an intentional manner in assembling this Action Collaborative. The composition of the organizations involved, coupled with input from the public that we will be collecting through vehicles like this webinar, will allow us to move forward in a more aligned manner. We want to hear from you. I cannot overemphasize that. We really do want to hear from you. We have been speaking about developing solutions throughout this webinar. Some of the products that the working groups are discussing are academic papers, toolkits, webinars or series of webinars, a website repository of curated resources and tools, interactive infographics and explanatory web pages, amongst many other ideas. This is where we would really like to hear from members of the public. What sort of resources would be helpful for all of you to have? What could we develop or disseminate that would help you do your job better in whatever field you occupy? Please feel free to send it via the Q&A tab on the webinar right now, or email it to opioidcollaborative@nas.edu. That email address can be found on our website, and we'd really appreciate hearing from all of you. This invitation for input and comment doesn't only extend to this webinar. We'd like to hear from you throughout the process, and especially as we start to release products and convene activities. Your input is absolutely critical in ensuring that we can truly provide interdisciplinary and multi-sectoral solutions that consider everyone's needs and fields of practice. I'm now going to turn the mic over to the leads of our 4 working groups so that they can provide you a more in-depth look at what each of the working groups are focusing on and what they plan to do over the next 2 years. Thank you again for your participation in this webinar and your attention to this issue, which is impacting so many American families and communities. And now I'd like to introduce Steve Singer, Vice President of Education and Outreach from the Accreditation Council for Continuing Medical Education, who will be presenting on the work of the Health Professional Education and Training Working Group.
Thank you, Admiral Gerard. As we begin this inclusive collaborative process, it's a pleasure. We're grateful to be able to share how our work is beginning to take shape in the Health Profession Education and Training Work Group. I want to thank my co-leads, both Tom Naska at the Accreditation Council for Graduate Medical Education and Kathy Chappell at the American Nurses Credentialing Center. You see here on the slide that our work group intends to be very inclusive and multi-professional in bringing together leaders from academia, federal agencies, health education and accreditation organizations, health professional associations, providers and health systems, nonprofit institutions, and the private sector. The mission of our group is to collaboratively develop a harmonized, interprofessional, patient and family-centered approach for the continuum of health professions education that addresses acute and chronic pain management and substance use disorders, inclusive of prevention, screening, intervention, treatment, and long-term recovery. The objectives, as Admiral Gerard described, are going to aim to provide actionable information, insight, and guidance to these audiences to, in number one, analyze current accreditation, certification, and regulatory requirements for health professions education that reflect acute and chronic pain management and substance use disorders, to identify professional practice gaps for healthcare professionals that currently exist in relation to acute and chronic pain management and substance use disorders, to curate evidence-informed educational tools and strategies to address these professional practice gaps in relation to acute and chronic pain management and substance use disorders, to engage stakeholders to adopt evidence-informed tools and strategies to address professional practice gaps in relation to acute and chronic pain management and substance use disorders, and lastly, to develop strategy to evaluate the impact of the adoption of these evidence-informed tools and strategies on health professions, education, and practice. So our goal, in summary, is really to provide guidance and resources across the continuum of health professions education with an interprofessional and patient-informed view. With that, I'm going to hand the presentation over to Helen Burston, co-lead of the Opioid Prescribing Guidelines and Evidence Standards Working Group.
Great. Thank you so much, Stephen. Delighted to join you today. I'm going to talk to you about our Opioid Prescribing Guidelines and Evidence Standards Working Group. I'm delighted to be co-leading this group with Deborah Horry, who is the Director of the National Center for Injury Prevention and Control at the CDC and has had a very significant role in the CDC opioid guidelines, so a perfect person to co-lead this work with us. And as you can see, we have also a remarkably diverse participation in this working group across really all sectors of the opioid prescribing and guidelines work. From academia, we have several federal representatives beyond Deborah as well, with CMS at our table, multiple health professional societies, providers, health systems, nonprofit institutions, payers, pharmacy, the private sector, and we really feel like with this group, we are ready to meet this challenge and have really had just incredibly interesting and exciting conversations to date. Next, please. So our mission and our objectives, which have been evolving as we've had each of our calls with this remarkable work group, have really been focused on how we can harmonize prescribing guidelines for acute and chronic pain through the collation and comparison of prescribing guidelines for both acute and chronic pain, while identifying critical gaps in knowledge where further research is needed to support those evidence standards. And the example we give here, for example, is guidance around tapering, something that you'll hear more about as we get into the objectives. And further, we think it's really important to not just have information, guidelines that will sit on a shelf, but we also want to think about how we can support implementation of these guidelines into practice. And very importantly, from the perspective of our work group, thinking about how we can also do that through measurement or other means, but also while monitoring for any unintended consequences to patients, something we heard loud and clear as part of our discussions to date. As I go through the objectives, I'll give you a little bit of our thinking of where we're going. This has literally been updated as recently as a couple of days ago. The first objective we think is very important, which we're going to begin collating and comparing the existing opioid prescribing and tapering guidelines. And we're going to look at that for specific pain indications where they do or don't diverge across specialties to see where the differences exist that really can't be justified based on available evidence. Can we go back through those guidelines, find out where there might be unintentional differences, where in fact being able to pull those guidelines closer together towards a more harmonized approach would make the most sense. I will tell you on our call yesterday, our group has in fact prioritized tapering guidelines as probably the most important piece of work that we can come out with, of really being able to share with the field where is the evidence, where is it needed, and begin providing critically important information to both patients and clinicians about tapering while we look at how best to collate and compare the other existing guidelines. Secondly, we want to highlight the value of non-pharmacologic treatments as complements to opioids for pain management, and specifically include recommendations to help, again, both health professionals and critically important patients, help them navigate barriers to their use. Again, looking at where the evidence exists for these particular treatments and where they don't, and also specifically making sure we identify where further research is needed. And then finally, we want to look at how we can best support the incorporation of these prescribing guidelines into clinical workflow, and whether that is through EHRs, clinical decision support, or even measurement. We want to, again, see how these guidelines can be used to really drive improvement. And as we mentioned in our mission statement, we want to do all of that while also keeping an eye towards how we can make sure that whatever is being done is not leading to any unintended consequences. And with that, I'm going to hand the presentation over to Alonso Plow, the co-lead of the Prevention, Treatment, and Recovery Services Working Group. Thank you so much.
Great. Thank you, Helen. I'm very happy to be representing the work of our group on prevention, treatment, and recovery services. I'm Alonso Plow from the Robert Wood Johnson Foundation, and I'm presenting this on behalf of my co-leads, Jay Bott for the American Hospital Association and Andre Ostjevsky from Solera Health. Like the other working groups, we've had a very committed group working with us, representing the multiple perspectives that are needed to understand the continuum of services and supports that range from prevention, treatment, and recovery. So we have academics and federal officials, health professionals. So much of the continuum is in community-based organizations and nonprofit institutions, people looking at this, members from the payer side, private sectors, and again, so much of this is also relates to public health and social service systems related to state and local health officials. So we have that mix of perspectives and very good dialogue around how we address this issue. So let me turn to the mission of this particular working group. Is to curate and develop and disseminate integrated approaches to prevention, treatment, and recovery services for opioid use disorder, including for vulnerable and high-risk populations, with guidance for how to implement, scale, and sustain them. As many of you on the call know, this is an ecosystem that requires a great concentration and effort to make sure that there are integrated approaches throughout the continuum that work for patients and clients from different walks of life. And I think that our overall guidance is how we can recognize and use evidence to find those approaches and build on them for guidance for how to implement, scale, and sustain those better integrated approaches. So our objectives follow right from that mission statement. Number one is to curate and disseminate the essential elements and components of the continuum of care, including highlighting systems barriers to integrated and effective prevention, treatment, and recovery services. Our group has talked about an ecology of individuals and sectors which are varying in their ability to be integrated, and how can we determine through case studies and other analysis what are the best practices for improved integration. So that leads to the second objective, share those best practices and bring awareness to both the barriers to implement and evaluate and scale those successful prevention and treatment and recovery approaches. We know that there are many examples of this, and we believe that through disseminating case studies, toolkits, as was mentioned earlier, we can help move the field forward to replicate and extend those effective practices. Number three, accelerate improvements in prevention, treatment, and recovery and care services for vulnerable and high-risk populations. We recognize that our services are not able to equally treat and reach and engage all populations, and our group has discussed a focus particularly on a variety of vulnerable and high-risk populations, such as criminal justice involved populations, homeless veterans, mothers and children, among others, that we should pay special attention to make sure that these integrated services work for them through the continuum of prevention, treatment, and recovery. So that is the work of our group. And with that, I will turn it over to Kelly Clark from the American Society of Addiction Medicine.
Well, thank you. I'm Kelly Clark, and I am very pleased to be a co-lead for the working group on research data and metrics, working with Carlos Blanco of the National Institute of Drug Abuse, physician and scientist who has a tremendous background to bring to his role. So I'm very pleased to be working with him on this, as well as the rest of our working group. Our disciplines on our working group include research scientists, lawyers, nurses, pharmacists, physicians, and business people. We include payers and providers, public and private sector representatives, as well as representatives from organizations which develop practice standards and those who assist with oversight, credentialing providers, and monitor for best practice metrics. All of the folks which you can see on the website that are part of this working group represent areas of expertise and organizations of expertise that are invaluable to the multidisciplinary approach that this collaborative is utilizing to address this crisis. Now, our group aims to collaborate with the other work groups around obtaining information that's currently available to address the entire collaborative goals. As you recall, the collaborative goals were to identify and raise the visibility of the complex challenges, outstanding research gaps, and needs for collective multi-sector response, to elevate and accelerate evidence-based, multi-sector, and interprofessional solutions to improve outcomes, and to catalyze action on shared priorities and solutions. So our group is called the Research Data and Metrics Group, but the outflow of our group is not focused simply on where additional research is needed, because there is a lot of information that is currently available to us, and our group is looking at a variety of pieces of work within our mission as reflected in our objective. So in mission, our mission is to address the barriers and promote solutions that are related to, first, data access, sharing, and interoperability, and secondly, quality measurement standards and evaluation criteria, and finally, to identify those critical research gaps and needs. In order to meet the mission, our objectives are to identify a plan for specific pathways to promote greater data transparency, interoperability, and sharing opportunities for the data. It's simply critical for us to utilize the information, the data that's out there, to pull it into more information and actionable information, and then to act on it. And on the acting on it, our objectives too, which is to collect, evaluate, and promote impactful standardized quality measures that are currently available related to the collaborative's mission and to the other work groups. So after we can look and see the information that's out there around impactful standardized quality measures, then we can look and see where are the gaps. And that's our third objective, to delineate the research, the data, and the metrics that are needed and not currently available, and the opportunities for those across the three other working groups: the health professional education, prescribing guidelines and evidence standards, and prevention, treatment, and recovery services, of course, working with those three working groups. So that's a brief overview of our research data and metrics needs working group. And with that, I'll hand this back over to Liz.
Thank you, Kelly. So I'm going to share a couple announcements from the collaborative before we move to Q&A. So first, I'm excited to announce that we are launching a new opportunity for organizations not currently involved with the collaborative to join the collaborative as network organizations. And in particular, we would really appreciate and like to increase the representation of patients and patient groups in our work. So this is a terrific opportunity to become engaged. So network organizations commit to developing and disseminating evidence-based strategies in the Action Collaborative's 4 focus areas. They are active supporters and contributors to the work of the Action Collaborative, but are not participating in the Action Collaborative's working groups, or at least currently so. Network organizations will engage with the collaborative in many meaningful ways. They provide input on activities of the collaborative, receive networking and information sharing opportunities, receive regular updates on the work of the Action Collaborative, including priority invitations to public meetings and advance notice of new resources and publications. They also receive communications tools such as infographics and social media kits that we develop, and are featured on the NAM website along with an organizational commitment statement which describes the current and or future work in the 4 focus areas. And of course, we'll receive invitations to act as partners in new efforts to combat the opioid epidemic. So those interested in becoming a network organization should visit nam.edu/opioidnetwork.orgs. On the website, click the link to complete the short survey, which will ask for the name of your organization and ask you for a brief commitment statement of no more than 500 words in either PDF or Word format, describing the current or future work in the Action Collaborative's 4 focus areas. So this statement will be posted on the NAM website, as well as the name and contact information for your organization liaison if you so wish to include that. And then my final announcement is that we will be holding a public meeting during the morning of April 30th, 2019 at the National Academy's Keck Center in Washington, D.C. Registration opens at 5 p.m. today, so please go to nam.edu/opioidcollaborative to register to attend in person or via the webcast. And more details about that meeting will be released very soon. So now we will turn to Q&A and open it up for questions and comments. And so I'd like to pose a first question, which is for Dr. Zhao. And this question reads, how did you determine that the topics of the 4 working groups were the most critical to focus on?
Thank you, Liz. I want to emphasize again, this is a collaborative. That is to say that it is the stakeholders that determine what we should be doing. But from day one, we recognize the uniqueness of this collaborative is across silos and discipline. And I'm sure that you would agree if you listen to the presentation of the different working groups that they cut across many different sectors and involve many stakeholders. By the way, I should recognize that we need more engagement in patient groups, and that's what we're doing right now. So that being said, how do we end up these 4 areas? Well, it's because the people who are involved with this identify them. So we had a couple of planning meetings back in January 2018, and then July 2018, we had 2 meetings, stakeholder meetings, that got together all this 50 organization and their representative. We also had a stakeholder survey. We sent out a survey to ask people, what do you think are the missing pieces and how can we uniquely in this collaborative can fill in the gaps? And so this stakeholder group, including federal, state, and local government, academia, subject matter experts, clinicians, health professional associations, payers, pharmacy business, nonprofit, patient group, and among others. So because of all that, people begin to say, you know, this is an area that is missing. Well, if you think about the ones that we've chosen, it plays to the strength of this collaborative. So for example, education. Well, we all recognize part of the problem of the crisis is related to the education prescribing habits, if you will, of the providers. So our question is, who's bringing together all the education enterprises that determines medical school education, residency education, nursing education, dentistry education, and of course, continuing medical education. And how can we bring this together to say, have we covered all the gaps? What's the right level of education at different levels? And how do we actually make sure that there is accreditation certification backing to looking at education? Prescription as a second one, and tapering, clearly another important space where, you know, if I go to a dentist and it gives me 7 days of Vicodin, which is a true story, you know, you would say, do I need it? So we need evidence-based decision. And there again, the uniqueness of the different groups of people and the NAM coming together to look at this. Prevention, treatment, and recovery, research data, all that has, as you can see, crossed the discipline. And it is the survey and the planning group that collaboratively say, collectively, these are the areas that we can serve and provide most outcomes, if you will. That's how they were chosen. So I would say that our job at NAM is to facilitate and convene and enable us to help these groups to come together to find the collective solutions.
Great, thank you. And then we have another question which asks, can you talk generally about the types of products that the Action Collaborative will be working on? Admiral Joie alluded to this a little bit in his opening remarks, but the types of products you could expect to come out of the Action Collaborative include expert papers, commentaries, or special publications, as well as webinars like what we're hosting today, expert meetings or workshops, print and digital resources as well, including infographics or an online resource repository as was created in our Clinician Resilience and Wellbeing Action Collaborative, case studies, including profiles of programs, organizations, and communities which distill translatable elements and key principles for success, as well as stakeholder outreach activities and terrain mapping. So that's just a broad sense of what you might expect. Turning back to our questions, I have one which I will pose to Alonzo Plow. Are there plans to look at addressing startup programs to the underserved, particularly programs and centers providing services to special populations such as HIV/AIDS, migrant workers, homeless, veterans, and prenatal mothers, and how these groups can develop and implement MAT programs?
Yes, excellent question. Yes, that there are, and we've had extensive discussions within our group around linking up with those of us who have experiences with this issue with those groups. I myself used to run large public substance abuse treatment programs, so that we do outreach, figure out best practices, learn from organizations and settings that are serving vulnerable populations better, and understand not just the service context, but also understand the social environment, social determinant context that may be barriers to effective engagement and treatment. So we want to look particularly with those populations in a social determinants framework as we understand how to improve systems of care for them. And we would really welcome any more connections to groups that anyone knows who are providing innovative approaches to marginalized and vulnerable populations.
Thank you. And now a question for Helen Burston. For the guidelines work group, will you compare opioid prescribing guidelines across the many states that have their own guidelines?
That is an excellent question. We have been mainly focused on looking at least initially, where the professional societies come down, but we recently talked about this on one of our calls as well. So yes, I think we will, in fact, take a look at anything that are state-based guidelines as well. It's a great suggestion. Thank you.
And Helen, another question for you. Will the opioid prescribing guidelines look into the usage of non-opioid alternatives, especially for high-risk groups that have a history of chronic opioid use?
Absolutely, yes. Actually, it's our second objective. We really do want to look to see what are the non-pharmacologic treatments out there that can complement the treatment of pain for patients. And I think an important area here in particular is really being able to identify where the evidence exists and where the evidence is needed. So yes, definitely a really important part of this work.
Thank you. And a question for Kelly Clark. For the research working group, are you including representatives from this is called the death care industry, coroners, laboratories, et cetera? Are you considering strategies for improvement in the collection and processing of death certificate data?
So that is also a great question, because from a surveillance standpoint, for us to manage the epidemiology and current threats, there is absolutely a lack of standardization across the way that deaths are reported. And that is an issue that we have discussed in our group, and it is absolutely on our radar.
Thank you. This is a question for Dr. Zhao. How will the NAM collaborative facilitate collaboration among the many federal agencies now acting sometimes in silos to address the opioid epidemic?
Well, we're very, very fortunate to have the direct involvement of Admiral Giroir, who oversees all the federal activities, particularly in HHS, but he's connected with all the other federal agencies as well. So from day one, we thought that this has got to be, public-private working together. And Admiral Giroir will be able to bring to us that connection. If he is aware of one area or the other that we should be working closely with. And maybe I can turn to Brett and see if, what he would like to say. Brett, I guess maybe Brett has dropped off, but certainly I think this trend of collaborative is to have in this case, HHS at the table with all its agencies, but he's also connected well beyond the HHS, so that's how we're going to be able to work together.
Great, thank you. This is a question for Kelly Clark. If we think of addiction as being a symptom of greater dependency, wouldn't we be better by addressing the underlying mental health of individuals as a preventive method for OUD?
Well, we think of addiction as a chronic brain disease, not dissimilar to other brain diseases, and the prevention is part of the prevention group actually, and might be better focused there. But as we look at prevention and treatment, we are looking at issues around co-occurring disorders, whether they be psychiatric disorders or whether they be what we would consider to be physical disorders. All of these have some impact in both prevention as well as our needs for interventions in managing these chronic disease. But I would defer to one of the co-leads on the prevention and treatment work group if you've got any additional comments.
Alonzo, do you want to comment?
No, I think you covered that.
Okay, thank you. Alonzo, while I have you, I have a question directed to you. Implementation of ideas requires in-depth excavation of two challenges: resistance to change and realistic scalability. Who is best to perform these analyses?
Well, that goes to the core of what we're really working on in our group, and trying to understand from some of the best practices what programs and approaches can be scaled and replicated. Does require some analytic specificity. Sometimes these are the reason they work are certain regional characteristics, certain characteristics of their care systems, and other local approaches that facilitate those innovations. So I think what you really have to do to look at this is draw on enough individuals who have experiences in a range of different types of contexts and settings, so that we can understand what works where. That's a very important question to be asked when you're thinking about scale and spread, because as everyone on this call knows, there are many contextual complications and nuances to how you connect the prevention, treatment, recovery continuum. Particularly prevention and recovery are deeply rooted in the social context of a place.
Terrific, thank you. Let's start with Kelly and then maybe move to Helen. Will the metrics work group collaborate with the guidelines work group to potentially develop associated quality measures?
Yes, That was an easy one. Thank you.
Yes, although I just want to add that I think we probably don't have the bandwidth to develop quality measures, but I think it would be very important for us to look to see what is out there, see what's been working, be able to look with what health systems have been using as part of their dashboards, and really begin to give the field some sense of what are the right kind of metrics to begin looking at. And again, just to emphasize one more time, I think also really importantly, making sure we keep an eye towards where those metrics could in fact be leading to unintended consequences.
I should actually give that a little more color. That is actually one of the objectives within our group, is to be working with each of these groups to determine what some of the metrics would be, so that we would know if the recommendations being made by the group were, by the collaborative in the end, actually were being put into play, put into use. Out in the communities, out through the stakeholder groups.
Thank you. This question is for Steve. Will you be scanning states for what is already required in CE requirements in opioid content for licensing and board certification and trying to standardize that?
Yeah, that's a great question. That has certainly started as part of our discussion. One of the approaches that we've discussed is taking sort of an environmental scan and creating kind of a matrix approach to look at either profession-specific requirements with regard to education, licensure and certification across states and from different entities, and also kind of doing some analysis to compare that against the practice gaps that are evident across health professions with regard to these issues, in order to gauge what insight and information we can give about how well or not those expectations are meeting the educational and training needs of practitioners in these different locales.
Great, thank you. And now this question is for Dr. Zhao. Can you describe the targeted audiences of the Action Collaborative's work?
Well, I want to say, first of all, the whole idea of doing this is to recognize how complex this issue is. So we're not talking about one audience. We have actually multiple audience, because it is the collective action that makes this public-private partnership so unique. So we're not focused on single audience, but much of the work is directed to, as you already heard, healthcare providers, policymakers, regulators, payers, clinicians, patients, families, and the broader public. And I think that when we talk about patient population, certainly as you heard earlier in the questions, and also the description by Alonzo, high risk and vulnerable populations. I think that if we're successful, and we should be, we'd like to change the practice of prescription. We'd like to improve the treatment and prevention. We'd like to address the social issues that plague many of the substance use disorder patients. And of course, subsequently, the ability to get off the addiction. We have to have the social environment for it. And we'd like to have certainly the payers and everybody enabling this to be successful. So I would say that our goal is to really make a difference. So it's not one target audience, but all the stakeholders together working on this. I would like to say that this collaborative, we're in this for a long haul. The National Academies, I know everyone who's been involved with this initiative, the people you heard, are in this for a long haul. Even though we say it's a 2-year collaborative, because this is how much we can say people should be committed to it. But truth of the matter is, in our own experience, we're going to continue working on this until this issue is greatly under control. And of course, we're highly dependent on everybody working together, and depending on the federal agencies and state agencies to work with us. Thank you.
Great, thank you. I have a more general question, which I think I'll pose to each of the co-leads, and it is, while educating clinicians on the current crisis is critical, education of patients and the general public is also key to overcoming the current state of the crisis. Are there plans for public and or patient education? Let's start with Steve.
Yeah, that's a terrific question. You know, I think within the lens of the education and training group, when we think about the scope of our, you know, the audience that we're thinking about, we are looking at health professions, but it's clear to us that patients and the public are part of the interprofessional team of care. You know, in evolution in the way in which, you know, for example, accreditation requirements for continuing education are encouraging the inclusion of patients and the public as partners in education is a big sort of a start in that direction, and I would expect that the work of our group will explore that further to see kind of what insight, what guidance, and what resources we can bring to inform a more inclusive and interprofessional approach.
Thank you. Helen?
Yeah, so just to build on what I said earlier, absolutely, we have very much considered how, as we look at this work around identifying the set of prescribing and tapering guidelines going forward, it's going to be really important that this go both to clinicians and patients. If it only goes to clinicians and it doesn't, and patients don't understand it, then we'll just get into, you know, really difficult conversations. So it needs to be, both sides need equal knowledge in this. We've had lots of interesting conversations about, for example, even mapping out the patient trajectory and creating some tools that both patients and clinicians can use to really understand how care is being done.
Thank you. Alonzo?
Yes, from our perspective, it's essential that we have ways to engage, materials to engage people in the community, patients, clients. For every person who's has substance use disorder, that individual that individual's condition is affecting a whole other network of caregivers and concerned people. The issue of stigma has to be addressed and understood at the community level, so that from our perspective, part of the solution has to be materials that engage the general population around that can improve their engagement, their trust in the system, and their ability to be well served as advocates for their own care and need in the system around substance use disorder. So, and we are already talking about ways that we could disseminate information that would be meaningful to those populations.
Great, thank you. And finally, Kelly.
Yes, thanks. Absolutely, we have been talking about this within our group as well. There is, you know, there continues to be a lack of understanding in the general public about opioid addiction as a chronic brain disease, about the differences between physical dependence and opioid addiction, about what the data shows us are evidence-based treatments, and what some of the metrics are to look at when people and their families and everyone in the community looks to see at what kind of a treatment program a certain program might be, what kind of care they should be looking for, what kind of outcomes should they be thinking about. This is critical, a critical piece, and it is something that we are talking about as well.
Thanks so much. Well, I think that's a really nice way to conclude our webinar since we are at the top of the hour. So I would like to conclude by extending our special thanks to our speakers and to all of you for participating. If you have any remaining questions or comments, please feel free to email us at opioidcollaborative@nas.edu, and we will do our best to get back to you promptly. A link to the webinar recording as well as a copy of the slides will be posted on our website within the next week or so. I think the slides might actually be posted right after this. So thanks again for your participation, and we look forward to hearing from you as the work unfolds. Thanks again.